Okay, hello everyone, and welcome to Stand Safe 2020. Thank you all so much for joining us tonight. I'm Dennis Chataltepe. I'm a third-year medical student at the University of Massachusetts Medical School.
And I'm Selena Dubin. I'm a fourth-year medical student at the Icahn School of Medicine at Mount Sinai. We'd like to begin by introducing you to one of SAFE's founders, Sarah Beth Spitzer. She is a second-year general surgery resident at the Brigham and Women's Hospital in Boston.
She's also the author of the newly published study, Incidence, Distribution, and Lethality of Firearm Injuries in California from 2005 to 2015, along with one of our other speakers tonight, Dr. Garen Wintemute. Sarah Beth, she is muted, but coming on now.
Thank you guys, just one of the many Zoom technical difficulties. So first, just a huge thank you to not only Dennis and Selena and obviously Dr. Wintemute for helping me step by step through that paper, but also Dr. Parsonet, Dr. Winslow, Dr. McLean. These are just a few of the people who have really totally taken over and led the charge for setting up both this event and also SAFE throughout the year. So just so many thank yous all around. So Scrubs Addressing the Firearm Epidemic, or SAFE, is an organization of US medical students, physicians, nurses, and healthcare providers across the board dedicated to eliminating the American firearm violence epidemic, really through research, education, and evidence-based policy. I helped found SAFE back in 2018 as a medical student at Stanford with Dr. Winslow and Dr. Parsonet in response both to just a constant and devastating stream of firearm injury events, coupled with the lack of information or medical student teaching that we experienced back at Stanford. So today, we really hope to recognize the need to frame firearm violence as a public health crisis, one which is both preventable and urgent. And we do so by aiming to advance research in gun violence prevention, educate healthcare professionals all the way from medical students up, and really aim to lead research in gun violence prevention, both about when and how to discuss firearms with patients, and more broadly, how to support evidence-based policies in the United States today.
So as an organization, we've advocated for federal funding of gun violence research along with Representative Jackie Spear and Representative Gabby Giffords. We've worked with California Assemblyman Mark Berman to develop a multifaceted education and training program on the prevention of firearm-related injuries and death. And we've also held a press conference at the US Capitol steps in June of 2019. We also hold Stand Safe in September every year for the past few years since we've been founded, and we unite our SAFE chapters through this event in our shared goals of education and advocacy for this cause.
Today, we have the privilege of learning about and engaging in a discussion on the links between firearm violence and two pressing issues in our world today, COVID-19 and systemic racism. Our speakers are renowned experts in these fields, and they've dedicated their lives to studying firearm violence and prevention strategies to protect both their patients and ourselves.
Each of our two sessions today will run for 40 to 50 minutes. At the end of the 40 to 50 minutes, once all of our speakers have presented, we'll be asking speakers questions from our attendees. Audience members, feel free to use the Q&A feature at the bottom of your screen to type out a question for our speakers, either for the group or for an individual speaker at any time during the presentation, and we'll answer these questions during the Q&A after all the presenters are finished.
Our Q&A sessions will be moderated by Dr. Julie Parsonet. She's one of the co-founders of SAFE, and she's the George DeForest Barnett Professor in Medicine and Professor of Health Research and Policy at Stanford University School of Medicine. She is an adult infectious disease specialist, and she studies the way that infections contribute to the development of chronic diseases. We are very lucky to have Dr. Parsonet facilitate the conversation with our panelists today.
Our first speaker today is Dr. Garen Wintemute, whose brief bio is on the screen, or will be in 1 second. Thank you. So Dr. Wintemute directs the UC Davis Violence Prevention Research Program and the UC Firearm Violence Research Center, and he's a longtime partner of SAFE. He will be introducing the topic of health professionals, violence, and social change. Dr. Wintemute.
Hi, everybody. Let me share my screen. And you should have slides full screen. Is that correct? Great, thank you. So I'm going to be relatively brief. I'm going to be introducing some themes that I suspect will occupy much of our time for both hours of this seminar, to which I've been looking very much forward. Starting, whoops, it's not shifting. 1 second. We do it here. Starting with the many links that we are experiencing, we are learning about between the pandemic and violence. First is a firearm purchasing surge. There have been 2 waves. We may see a third. You're going to hear more about this. Second has been the effects of stay home orders. In March, when these orders came on, we thought we would see perhaps a reduction in community violence, an increase in domestic violence because people were going to be staying at home. We thought those might be difficult to measure. When the orders were lifted later in the spring, we thought we would see a resurgence in community violence simply because people were back out in the community. There is the disease itself and our responses to it beyond just the stay home orders, all of which have led to unemployment, both in a rapidity of onset and of a magnitude that we simply have not seen before, to society-wide, planet-wide isolation, to extended periods of, excuse me, loss of access to food, to healthcare, all of which has led to, not just in this country, but globally, a time of fear and loss and daily grief and uncertainty that has gone on for much longer than all but the most pessimistic of forecasters thought would be the case in the spring. Superimposed on which has been a more public attention to continuing violence by law enforcement, a growing reaction to it, and a very strong reaction to that reaction, bringing to everyone's attention forms of violence that have been there, but largely under the radar until just the last few months. Add to that what I'll summarize simply as Washington, an administration that many, including me, would argue has been actively promoting violence and at the same time vilifying science. And I'm just going to stop there because I could spend the rest of the time talking about that. But all of this has led to a sense that some of these changes may be permanent, effects on children due to a lost year of education and so forth. And I think a general expectation that things may get worse just in the next few weeks, even before they get better. We all are not spectators to this. We are living through it. So as I suspect all of you know, it's made the answer to the question, so how are you, a little bit complicated. We are starting to use apocalyptic terms as we describe the present time. And I'll just point out that yes, we do at this time satisfy the 4 horsemen criteria. We are experiencing forms of civil warfare. We are experiencing pestilence, famine, and death here in the United States. So be it. It has fallen to us to live through this time. We have work to do. I'm going to show you some new science and make some recommendations for things that we can do. Starting right here. These are survey results, a survey that we conducted just in July. The ink is still wet. We are still fine-tuning the numbers. This is the first public presentation of this work. We did a population representative survey sample of California residents. The survey was designed before the pandemic started, but finalized in the midst of the pandemic, altered to account for the pandemic. And we asked people a lot of questions about how did it used to be and how is it now? The survey was conducted in July, about 2,900 California resident adults. What we learned was that large percentages of people, as you can see, are very worried that they themselves might be the victim of serious violence. The proportion thinking they might be the victim of police violence is as high or higher than the proportion thinking they might be victims of violence of other sorts. These are increases of between 5 and 10 percentage points since before the pandemic. 5% of the adult population reported a new concern that they themselves might be the victim of domestic violence. 12% of the population, 1 person in 8, reported knowing someone they thought was at high risk of doing violence either to someone else or to themselves. It's 12% each of those. A substantial proportion of those at-risk people have access to firearms. 2.5% roughly of gun owners acquired a firearm because of the pandemic. Just in the months immediately preceding the survey, nearly 1 in 5 stored firearms loaded and not locked up. And for most of those, that was a change in behavior in just the last few months towards less secure storage. But something that we all are taking as very good news, remarkably, more than half, not just of firearm owners, but of respondents to the survey said that they had taken some form of public or political action, donating, letter to the editor, something along those lines, in response to gun violence. That's how the question was asked in the 12 months prior to this July survey, and almost a quarter just in the last 2 months before the survey. So this leads me to some things that you as clinicians can do. I want to confess a bias on my part. I think the answer to what should I do should precede the answer to the question, what should we do? Personal commitments make all the difference. So one thing is study up on this issue. You're here to do that. There are lots of resources available. Let me note that on the right are logos. I'll come back to those in just a minute. There are lots of resources available now and more coming very soon to give people lots of information on how to be ready for individual clinical encounters. Clinicians report that impediment number 1 in talking to patients about firearms is, I don't know the issue. Well, that's fine. It's our job as clinicians to study up when we don't know. The second personal commitment is to raise the issue with patients when it's appropriate. The second barrier that clinicians report is, I don't have time enough. Well, that's fine. Don't ask questions about firearms all the time. Ask when it's appropriate. And I would suggest that there are 3 times when it is. Number 1, there's an emergency. I'm going to kill myself. I'm going to kill somebody else. You know what I'm talking about. Number 2, when patients exhibit or have in their histories risk factors for violence. We'll talk about those in just a second. And number 3, when people are demographically at risk, kids, young adult males, older men who are living alone, demographic groups who are known to be at risk as a group, whatever their individual histories may bring. Number 3, in individual encounters, we should be tailored, flexible, respectful, as we are when we talk to our friends, as we are when we talk to patients generally. Let me give you an example that I like a lot. When I'm talking, as I do all the time, about obtaining custody of firearms from someone, I use the verb recover. Let's recover those guns. Sometimes I will use, let's move those guns into safekeeping, something like that. I have colleagues, particularly in law enforcement, who like to use confiscate. Are you kidding me? The proper response to confiscate is something like over my dead body. It's just not productive. Prosecutors, no offense to the lawyers on the call, prosecutors like to use dispossess. That's what a heartless landlord uses. It's just the wrong verb. And I have colleagues in mental health who like to use the verb surrender. Talking to a depressed veteran whose identity is tied up in firearms about surrendering them, I should just put the barrel to my head. It just doesn't work. We need to use words that are motivating. Recover is a good one. The one I like best comes from a gun dealer who says he will often tell a client some form of, hey, Bob, how about I babysit your guns for a while? Babysit. It's temporary. It's not threatening. We need to choose language and choose an approach that is going to work. We can have some concrete goals, preventing acquisition, if that's the issue on the table, but more often than not, that's not the issue. We can improve storage at times of emergency. We can reduce access. Barrier number 3 that clinicians report is it's going to make patients angry or uncomfortable. They don't want me to talk about it. I want to preserve my relationship with my patients. By and large, that is simply a myth. Here is some research based on the first iteration of our survey work. This was published last year. The information was gathered a couple of years ago, this time about 2,500 people here in California, more than 2/3 of whom, and more than half of the gun owners among whom, said that it was at least sometimes appropriate to ask routinely across the board, independent of who the patients are. And 90% of respondents, more than 85% of the gun owners, said it was appropriate to ask about firearms when any risk factor was present. And we listed them one at a time. Any history of drug or alcohol use, suicidal ideation, dementia or some other form of cognitive impairment, a prior history of violence. There is a varied degree of support for asking when the question is most urgent. So fair enough, back to that time limitation, don't always ask. Ask when it'll do the most good. 84% of the population, 70% of firearm owners, routinely asking when kids are in the home, a group at demographic risk. 85 to 90%, including the owners, support each of the interventions which you see listed there when risk is imminent, which includes calling the police. And I'll remind you that if I have my count up to date, in 19 states now, calling the police can lead to an extreme risk protection order. We can talk about that in the Q&A, a mechanism by which, following due process of law enforcement can intervene in a crisis and recover those guns, have somebody babysit them until the crisis is passed. And the finding I didn't put on the slide that I like the best about targeting this intervention is this. Going back to that top bullet point there, 20% of the respondents said it was never appropriate to ask routinely. But of that 20%, more than 80% said, no, but it's always appropriate to ask when risk is present. Fair enough. Ask the questions when risk is present and be confident that the vast majority of the time, people will support your action. And finally, and I'll be brief here because I think we'll be spending a lot of time on it later, let's talk about the things that you can do in public beyond the usual narrow confines of the clinical encounter. It has been the most positive development of the last 5 years or so with regard to our response to violence, that groups like healthcare as a profession that traditionally have been on the sidelines have said, nope, this is my lane, I'm in, and we're going to do something about it. We are again refocusing upstream. I've listed some specific targets for such refocused action, support for community level violence prevention, for improved criminal justice policies and practices. You can read the rest of them. I've listed at the bottom there, attention to and action on the structures that engender violence. I will simply say here that if we don't change the structures that engender violence, we can expect at most limited returns from acting on any of the points that are listed higher up in that list. And finally, I'll just say, be in this for your lifetime. Do everything you can do. It won't be enough. It won't be that when the generation that comes behind you is done, that won't be enough either. And don't look left, don't look right, look within. It's going to be your action that will make the difference. I'll stop with this. Thanks. That's how to reach me. You see there the URLs for a long-standing resource, the What You Can Do program at UC Davis, and a brand new one, a very deep website with lots of links to resources designed for practicing health professionals that will launch next week. Thank you very much, and I'm looking forward to the rest of the discussion.
All All right, thank you so much, Dr. Wintemute, for sharing your wisdom and your perspective. Now we're going to hear from Julia Schleimer, who is a research analyst at the Violence Prevention Research Program, and who has done research in this field with Dr. Wintemute as well. She will be discussing their recent publication, which is focused on the association between changes in firearm purchasing and increased violence during the global pandemic.
Thank you very much. Let me just share my screen here. Can you see that?
Yep, we can.
Okay, great. So first of all, thank you so much, Dennis and Selena, for organizing this and for having me, and to the entire SAFE team, and also to my team, which has been very helpful in getting this research out, particularly Garen, who is senior author on this. So today I'm going to be talking about firearm purchasing and firearm violence in the first months of the pandemic here in the US. As background, we know that firearm violence is among America's leading causes of death and disability. This is data from 2018, which is the most recent year for which data is available, and almost 40,000 people died from firearm injuries, including 61% that year to suicide and 35% to homicide. And a large and growing body of literature has documented an association between firearm access and increased risk of firearm injury. And in particular, and what I'm going to be talking about today, is surges in firearm purchasing. So surges in firearm purchasing acutely increase the prevalence of firearm ownership or the availability of firearms, and have been documented in response to mass shootings and significant political events. And research has shown that they are followed by population level increases in firearm violence. And assuming these exogenous events that are associated with surges in purchasing, mass shootings and political events, don't affect violence through pathways other than the surge in purchasing, this provides a sort of natural experiment to disentangle the association between firearm access and firearm violence from other factors. And it allows us to better disentangle the temporal ordering of these factors. And so, as I mentioned, previous research has documented an increase in firearm violence following surges. So it's plausible that we would expect to see a similar increase now in response to the current surge that we see during the pandemic. And at the same time, as Garen mentioned, we're also in a unique time. Other than the surge in purchasing, there are a number of factors that are changing. Stay-at-home orders, for example, could increase risk for violence at home, potentially decrease risk for violence in public if fewer people are in public. The pandemic has also exacerbated factors that contribute to risk for violence, such as economic instability, tension, trauma, and generally putting strain on community resources. And so our objective here is to estimate the association between changes in firearm purchasing and interpersonal firearm violence during the first months of the pandemic. For this study, we used a cross-sectional time series design, including monthly state-level data for the 48 contiguous states and DC, and Hawaii and Alaska were excluded because of missing or incomplete data. And here we focus on the period of January 2018 through May 2020, although we are updating our analyses with more recent data, but this analysis is focused on the period through May. So our primary exposure for this study is a proxy for changes in firearm purchasing. And we measure firearm purchasing with the FBI's national instant criminal background check system for records specific to firearm purchase transactions. And we generate a measure of excess purchasing by predicting the expected rate of firearm purchasing in each state and comparing that to what we actually observed. And to generate the expected rate, we used each state's historical data, incorporating seasonal trends, secular trends, and each state's patterns of purchasing previously to predict what we might see in a normal time. And the difference is excess. Our outcome is firearm violence, and specifically we focus on interpersonal firearm violence. And we do that, well, might differ for different types of violence, but also we're using data from the Gun Violence Archive, which is the only real-time data source for firearm violence in the country. And data on suicide are not available in that same real-time way. So here we focus on intentional interpersonal firearm violence, including both injuries and deaths as the outcome. And for our analysis here, we then link excess purchasing within states to changes in firearm violence within states, while controlling for a range of factors that might confound the association. So we control by design for time invariant characteristics of states and any temporal effects that affect all states similarly. And in addition, we include state-specific time-varying factors, such as those listed here, COVID-19 cases and deaths, and stay-at-home orders, etc. And what we found is that there was a substantial surge in firearm purchasing near the onset of the pandemic, particularly beginning in March of 2020. So the red line here is the observed purchasing rate, and the blue indicates what we would expect. The blue line is the expected rate, and the blue bands are the prediction interval around that. And so in this 3-month period, we estimate a total of 2.1 million excess purchases, which is about 64% increase over expected volume. And this increase in this 3-month period was most pronounced in March, with 950,000 excess purchases that month alone. In terms of firearm violence, there was also an increase nationally during this period, although not above expected levels in March or April. But in May, we saw a substantial increase in firearm violence with 633 excess injuries that month alone. And when we link these changes in purchasing to the changes in firearm violence, we found an association such that for every one excess purchase per 1,000 population, we found that the rate of firearm violence increased by 1.015 times, which in sort of real terms translates to about 776 additional injuries, which is an 8% increase over expected if there had been no surge in purchasing. So there are a few conclusions that we can draw from this. First is that there was a significant increase in firearm purchasing and firearm violence during the coronavirus pandemic. And states with larger increases in firearm purchasing experienced larger increases in firearm violence. So there was an association between these two changes. And that degree of excess was substantial, with 2.1 million excess purchases in that 3-month period alone. And so several implications. The first most direct conclusion we can draw, which is tentative because this is observational research and we can't necessarily infer a causal relationship, but it's that limiting the surge in purchasing might limit a surge in firearm violence. At the same time, following a surge, once firearms are already in the hands and homes of Americans, it's important to focus on firearm violence prevention strategies and address the compounded risks that the pandemic presents. So, for example, strategies that support safer firearm use and storage, and that can include, as Garen mentioned, an important role for healthcare professionals in this time. Not only, this isn't something that needs to happen in person, so obviously that is limited during this time, but telehealth still presents that opportunity. And then thinking about the contributing risk factors, there are sort of widespread increases in anxiety, grief, economic strain, a deepening and exposing of racial and economic inequities, and disruptions to daily routines with statewide stay-at-home orders and social distancing guidelines. And there are several interventions that could be particularly useful in times such as this. One that Garen had mentioned earlier are extreme risk protection orders, which provide a temporary way to separate somebody in crisis from their firearms. And community-based violence intervention programs may also be particularly useful during this time, insofar as they can help address not only firearm violence, but the upstream fundamental causes that contribute to risk for firearm violence. And additionally, there have been, although we don't yet have great data on it, but we will soon, but there have been media reports that the current surge in purchasing is in large part driven by a desire for self-protection and concern for personal safety. And at the same time, we know that firearm access presents a substantial risk for injury, firearm injury and death, with no unique benefit for preventing crime. So it seems from this that there might be an opportunity or a need to address possible misperceptions about the risks and safety of firearm ownership. And several limitations are also worth noting. As I mentioned previously, this is an observational research study, which is vulnerable to confounding, as is all observational research. We sought to mitigate this bias, but we can't necessarily infer a causal relationship here. Second, our design is ecological and it lacks some specificity. So we don't have data on whether the firearms purchased during this period were those used in violence. And we don't have information on motivations for purchasing or on those affected, injured, those who died or were injured by firearm violence during this time. There's also potential for measurement error, both in our measure of firearm purchasing and firearm violence. So the background check data that we use are somewhat imperfect measures. It's a somewhat imperfect measure of firearm purchasing, although we expect that any disparity or deviation from background checks as a proxy for purchasing would remain relatively stable over time. And the Gun Violence Archive, which is our source for firearm violence, is gathered from news reports and media and law enforcement and a whole range of publicly available sources, which in the current time, there's potential for some undercounting as local newspapers may struggle financially or even shut down. Fourth, we measure this association in the short term. And this is a relatively short period of observation, and the world is changing very rapidly. So the results that I've presented today are limited to the period of observation for this study, which extends through May, although we are working on updating our analyses now. And lastly, we focus on interpersonal firearm violence. And we haven't yet examined other or more specific types of firearm violence, including domestic violence or suicide. Although again, that's coming down the line for us. On that note, there are several opportunities for future research, and I won't go into all of these in detail, but in general, there's a lot more research that needs to be done. I suspect that researchers will be studying the current increase in violence for years to come. There are a lot of factors that contribute to firearm violence, and there are a lot of factors that are changing in our world right now. Some important areas for future research are to try to understand factors that might modify the association between purchasing and violence, such as firearm laws, and also to look at this association at other geographic units. We are currently working on a city level analysis, and to identify factors that are contributing to the surge. So motivations for purchasing at the individual level, and factors at the community or state level that might have also contributed to some states, in this case, states experiencing greater increases in firearm purchasing than others. So thank you very much. That's my contact information. And again, just want to thank both the funders of this research and my collaborators.
Thank you so much, Julia. Perfect. We'll now transition to Professor David Studdert, who is a professor of medicine and law at Stanford University School of Medicine and Stanford Law School. He's a prolific scholar on health law and the influence of the legal system on the well-being and health of populations. He will continue the conversation today on spikes in firearm purchasing in response to COVID-19.
Thanks, Denise, and thanks to Selena for organizing this. It's a great forum on a really important topic. Now, let me see if I can find my slides here. Yeah, so we're running a bit long in time, I think. So why don't I just make a few comments? Can everybody hear me, by the way, and see my slides? Looking for a thumbs up.
We can't see your slides.
You can't?
No.
Okay, all right. Let me try again. I apologize. That's not going to help with timing here. How's that?
That's great. We can see them.
Excellent. So I thought in just a few minutes, I would just make a few remarks about the broader picture here. I think Julia's done a really nice job of trying to get an early look at the nature of this relationship. It's a really important relationship for policy reasons. It's a pressing public health question. And of course, it's a fascinating research question for those of us interested in firearm violence. But it's a hard question. It's going to be a hard question to quantify, even with better data later on. I think Garen and Julia have sort of set the scene nicely here. Many of us have seen the newspaper articles on what happened with purchasing, particularly early in the pandemic, in March and April, as apprehension and uncertainty rose. I was particularly disturbed to hear about higher rates, anecdotally, of purchasing by Asian buyers, traditionally a low purchasing group, at least here in California. And the reported concerns were out of fear of retribution from the source of the virus. So lots of social dynamics underway, but pretty clear evidence that we have a spike over the last 6 months, particularly again in those earlier months. And it's sizable. So here the New York Times data journalists have done their thing and compared it to some other spikes that we've seen in recent years. When you see data like these in the news, it's usually coming from background checks, from federal background checks. That's not a great way to count gun sales, but it's about the best way we have nationally. There's a whole variety of reasons why this represents an undercount in some respects and an overcount in other respects, but I guess the sort of take home here is that it's mostly an undercount because it doesn't, of course, register guns that are bought without background checks, and that's a very substantial proportion of all firearms in the United States. Here was my little snapshot from gathering the NICS data this morning, much less elegant than Julia's, but each of these colored bars represents 18, 19, and 2020. And you can see pretty clearly that there's a sizable spike here. We're up about 40 to 45% on background checks in 2020 from 2019. Interestingly, we were up about 30% already in January and February before the pandemic hit. So some other things going on. We've done a little work in the past looking at purchasing responses to social shocks, particularly to mass shootings. In this paper from 2017, we focused on mass shootings, specifically the Newtown Sandy Hook mass shooting in December 2013, and also the San Bernardino mass shooting in late 2015. And we were focused mostly on handgun sales in California. And we did a similar thing to what Julia, Garen, and their colleagues did, is we tried to sort of parse out how much of this was really due to the shock of a mass shooting and how much was due to just cyclical patterns in gun sales. Gun sales are seasonal, so it's important to sort of steady those effects as you look over time. But the lower line here represents a sort of statistical estimate of what we expected gun sales would have been in the absence of the shootings, and the upper line represented what we actually saw. So it's really the space between these lines after the shooting, represented by the dotted red line, that we think about as kind of excess sales that we attribute to the event. The bottom line really from that work was that there were these very substantial spikes. They tended to atrophy. I noticed there was a question in the chat about how enduring these kinds of spikes are. They did tend to reduce or decline over time. Importantly, we found about 30% of these excess sales were to people who hadn't previously purchased handguns in California. One of the reasons we used California data was because we had that sales history. And this is really important as we think about what kinds of effects we might worry about here. A gun sale to a household or a person that doesn't have one is a very different public health concern than one to a household that already has multiples. And most gun sales are actually to people who already own guns. And so in understanding the response to the pandemic, we need to sort of pass between those different kinds of sales. We also saw signs of smaller purchasing responses to other things that were happening across these timelines we were looking at, like terrorist attacks and President Obama's re-election in 2012. So it's plausible that we would expect, the biggest social shock, certainly of my lifetime, would also create one of these major spikes. But then, of course, the question is, how does that flow through to effects on rates of firearm violence? And as I suggested at the beginning, it's a complicated question. I've read a number of stories in the media, I suspect some of you have as well, about how COVID is a shocking event, but it represents such an amazing opportunity for research because we have this natural experiment where we can look before and after. I would say that's probably not true for many of the questions we want to ask in firearm violence. It's not true because we have the old problem of having pretty crummy data at the population level to work with, but it's mostly not true because the pandemic, as Julia noted, has also produced a number of social problems and forms of social unrest that actually are going to make it really hard to disentangle this relationship between the pandemic and what's happened in gun sales. And Julia and Garen have already touched on this, so I'm not going to dwell on it, but let me just kind of sketch out how we as researchers might try to think about this. So let's just set aside the rise in gun sales for a moment and not ignore the fact that the pandemic has produced a very, very intrusive, crippling set of public health orders and response measures across the country. We're all living under them. That's why we're meeting today on Zoom. Now, they have a variety of social effects in their own right. We've talked about declines in mental health, increasingly documented and not surprising. Social isolation, extensive periods of time at home, economic effects, and of course, housing insecurity, and a variety of other social disruptions. Now, they're importantly also associated with rates of firearm violence, potentially. Each one of those, there is a very plausible story, and in some case, good evidence making those links. They're related to each other as well, which we need to be careful about. So we would sort of think about these in epidemiology as being kind of mediators. Julia mentioned it toward the end of her talk. So they don't necessarily disrupt our ability to measure this relationship between the pandemic and what's happening with firearm violence, but they do explain how it's happening. So if we really want to look inside the black box and understand how it's happening, then we need to take account of some of these factors. And of course, they're also associated with rises in gun sales. Each one of those, we could tell a story about that association. And then there are other things that are really potentially completely independent of the pandemic, and both resulting in rising gun sales and changes in rates of firearm violence. Now, I personally don't think that the race tumult and tensions we've seen in the United States over the last 6 or 8 months are independent completely of the pandemic, but at least part of them reflect a much longer standing problem and cause of social unrest. So this is actually much more insidious and problematic for understanding the relationships, because this is an independent cause in epidemiology, a confounder for something that might change rates of gun violence independent of the pandemic. So it's hard to disentangle these relationships. We're not going to do it quickly, but I think what Julia and her colleagues have done is about the best we can do in the short term. We should remember, though, when we draw these simple causal lines, there's a lot going on in the background. The other thing I would just say in just a minute or two is, as Garen has taught me over the years, there isn't one epidemic here. There are multiple epidemics. So what we're eventually going to have to do is sort of disentangle this outcome we care about, firearm violence, into its different constituent parts. And chiefly those parts are suicide, accidental death, and homicide. And we don't necessarily postulate the same effects of the pandemic on each of those. I think it's pretty clear that the most plausible story for suicide and firearm suicide is going to be an increase as a result of the pandemic and the shutdown and the social isolation and the increasing rates of mental illness that I spoke about a moment ago. Similarly, long periods of time spent at home, including for kids, is probably going to increase everybody's exposure to accidental firearm deaths. And forget the spike in gun sales. For the third of American households that already have guns in them, there's a dangerous exposure, and now we have a much more prolonged period of connection with it. Homicide is really tough, actually. It's hard to know which direction this is going to go in. I think Julia's presented some provocative evidence. We don't have really great data at the moment on firearm homicide. We do have some information on crime, however, and most of the early crime data suggests that crime has gone down quite substantially, driven largely by a much lower rates of drug crime. Not surprisingly, much of that is street crime, and the streets are much emptier than they were 6 months ago. I don't quite believe the 18% reduction in domestic violence. That's probably a product of reporting, or an artifact, I should say, of reporting. If you're locked inside the house with your partner and you're being abused, it's pretty hard to make that call and take evasive action. So I suspect we'll find in the longer run that domestic violence goes up, but particularly domestic violence involving firearms. But I don't think the crime homicide story is going to be a uniform one. I think it's going to look different as we move across these different types of homicide. So with that, let me stop and let's get to some Q&A.
All right. Well, thank you all so very much. This is Julie Parsonet, and I'll be leading the Q&A. And we have a number of questions from outside that, and I have a few questions also myself. So first question, I guess, is on a global level, and this was asked about whether, well, actually, let me just step back for a second. I really want to thank all the speakers because you were all fantastic. And I also want to thank again, Dennis and Selena for putting this together. That was just a fantastic group of talks. But I'd like to get to the questions that people asked. And one of them was about worldwide. So there are other countries that allow gun sales, some in Latin America and in Europe, a few. And is this an American phenomenon to see these spikes in gun sales with stresses like this? Or does this happen in other parts of the world as well?
David or me?
Who are you pointing at, Garen?
I'll put that one to David, actually.
Yeah.
I have, the short answer is I have, I haven't personally done research on that, Julie. I have read anecdotal reports that there have been rises in gun sales in other parts of the world, but nothing to compare to the United States. As you know, Julie, the gun sale process is much more highly regulated in other parts of the country, in other parts of the world, I should say. I think also the harsh reality is that the United States has been much harder hit by the pandemic than many other countries. So the level of social unrest and fear and apprehension caused by it, except in the case of a few countries, doesn't really compare. So I think that combination of tighter regulation of gun sales, the greater difficulty that people have in most Western countries, most rich countries of accessing weapons, and then the lower impact of the pandemic have combined to make this a much less sort of newsworthy phenomenon in those places.
Thanks. Here's a question. This is actually from me, Garen, to you. First of all, I loved your words about babysitting and recovering of guns. And I thought that was just, that language is just great. And I'm wondering about whether video visits provide us with a real new opportunity to talk to people about their weapons at home and actually see what they do with them. And whether, I've been impressed as a physician who does a lot of home visits that, you could see people's homes and you could see where they're living and how they live. And it gives you a chance to kind of talk to them a little bit even more intimately about their homes. And I'm wondering if you see that as an opportunity for us, because I imagine we're going to be doing video visits for a long time into the future.
Yeah. And even when we're not constrained and forced to do video visits because of social distancing, that might be a real easy way to expand access. So agreed for a number of reasons. There aren't any data. I like house calls too. I actually make house calls out of the emergency department from time to time. But I'll say this, the best randomized trial of an effort to improve storage behavior, which is a big part of what we're after here, involved home visits, in part to do a home assessment prior to an intervention, and in part to monitor adherence to the intervention. So I think it's a great idea. I'm sorry, I meant what I said. These home visits would have to be by video in response to your question. We'll need to think this through a little bit separately because unlike a video visit for some other medical problem, there is the possibility that the video visit, when it's related to firearms, might acutely elevate risk. And I think we ought to at least think through, we've encountered this because we've been contemplating doing some interviews and stuff. What happens if the course of the interview acutely elevates risk for the interviewee and the interviewee is 300 miles away? What do we do? But I think those are implementation issues that need to be addressed. I think it's a great idea.
This gets, I think you mentioned some of this, David, as well, and also Julia. There's a question raised about, do surges result in just a small, do you expect them to create just a blip in gun violence, or is it just really having more guns out there is just going to lead to more gun violence for a long period of time? And David, you kind of also mentioned that it might just be new gun owners that would drive that because other people already had access to guns. So I'm going to ask Julia first whether you think this just having more guns out there is going to be a problem for years to come, or whether you think it's really related to this particular outbreak, and once the outbreak is over, or once some of the race issues are calmed down, that these guns that are bought now are going to sort of disappear into a closet and never be seen again.
Yeah, it's a great question. So some research by members of our team did a similar study looking at spikes in handgun purchasing in cities in California, and found that a year later, those cities that experienced the highest spikes experienced greater levels of firearm violence compared to cities that had smaller spikes. So there does seem to be some sort of enduring impact here. And I'm also going to reference work by David and Garen showing that the risks of having a firearm, having access to firearm, having it in the home, et cetera, are not time limited. So this was a study, and I will let the people who actually worked on it speak about it, but of suicide, finding substantial risk associated with firearm access for years after purchase.
We're getting some really great questions, and I know that we have to be conscious of time. So Emmy Betts, who herself is a great expert in firearms and interventions, asked about what you would like healthcare providers to do in 2021. And should we be out there fighting for CDC and NIH funding, more of that, better data? Should we, what should we be trying to do? Where in your, your imagination of the best things that we could do as physicians, what would those be?
So I'll start. Don't choose. There's a long list of things that we can do, and among the group of us, all of those things can be done. Individuals in the group should choose the things that that they're most capable of and most interested in doing. So individual encounters, by all means, when it's appropriate, ask. Should we be advocating for increased funding for research? Of course. Should we be advocating for increased funding for programs, interventions based on the findings of that research? Of course. Should we be advocating to change the basic social structures that engender violence? Of course. Let's do it all, and I'll stop there. Anyone else have David or Julia? What are you, just to give you?
Can I jump back to your last question, Julie? Because I think that it goes to the sort of heart of our session, and I realize we're right on time here. But my view is that the biggest impact of COVID-19 on firearm violence is going to be among the 1/3 of American households that already have guns. I think if you think about the time at home, the stresses, the potential for domestic violence and other things, it's really going to come from this enormous stock of weapons that are out there. If we look at these spikes in the context of even just 1 year of gun buying in California, a relatively low gun buying state, they're really only a small percentage of the total gun sales that occur in the state in any given year. So, it's definitely an interesting and important public health issue, the new gun sales to people that haven't had them before, but we should keep our eye on the ball here, and eye on the ball, and the ball is 1/3 of American households have firearms in them, and we have all these stresses and strains overlaying that home environment right now.
Okay. Well, one of the other questions that was asked, so we're going to have to move on to the next session, and which I believe is about to start at 4. And one of the remaining questions that I didn't answer was really about how we disconnect the twin epidemics that are going on in the country, which is of COVID, but also of the racial issues that we're seeing throughout many cities around the country, and some of the protests that are going on nationally for equity. And so disentangling those can be quite complicated. And so I'd like to just use that as a lead into the next session that we're going to have regarding race and gun violence.
Thank you, Dr. Parsonet, and thank you so much again to our group of speakers for such an amazing series of presentations on how the pandemic has affected all of us so deeply and how it's influenced the sale, distribution, and use of firearms. Learning about these changes is crucial in our efforts to remain strong advocates for our patients and their safety in the face of firearm violence. Now we're going to go ahead and transition to our next session on the intersection of firearm violence and systemic racism. We've long known about the disturbing, disproportionate rates of firearm homicide affecting Black communities that point to a significant racial health disparity, and we have the opportunity today to learn from our experts on what we can do to start making a change.
Please join us in welcoming Dr. Gary Slutkin, our first speaker. Dr. Slutkin is the founder and CEO of Cure Violence Global, a leader in epidemic control, public health, and behavior change. He's also the former director of intervention for the World Health Organization. Today, he will be presenting on the links between COVID-19, racism, social change, and the upcoming election.
Hello, thank you. Happy to be with you, and I'm going to go right ahead to sharing the screen. And let's see, here we go. Okay. Can you hear me okay? Yes. All right, so this is going to be kind of a transition from the first session to the next. And as was mentioned, I come from, I'm having worked on epidemics, other types of epidemics in other countries, in particular in Africa and in Asia. And I've seen these kinds of massive epidemics before. And I've been back in the US for about 20 years working on violence. And I'm going to talk about the challenges to the moment and how the epidemic playbook kind of works towards or needs to be thought about in the context of all of these issues that are going on, and maybe break up some myths. And we're going to talk about violence, COVID, the violence associated, the social justice, the multiple epidemics, which always occur in the context of any epidemic, and the election. And race is the frame and the context for almost everything in America. Race is frequently brought up in the context of violence, but I want to start by pointing out that violence is a human characteristic, but it behaves in a contagious way. And so that the idea here is that although there's a framing of violence around certain populations in America, it's not the reality. It occurs in populations all over the world, and it's related to exposure. So when we say it's a public health problem, we're also saying that the person who does it, not just the person who is shot, has a health problem in the first place related to exposure. And I'm going to unravel that and then go to COVID and then how all these problems relate to each other. So violence behaves in an epidemic way. And the greatest predictor of any violent event is a preceding violent event. As for COVID, as for flu, as for cholera, the greatest predictor of this particular problem is having been exposed to it. And the science of this now shows violence to be essentially a contagious disease because it meets all of the criteria and the definitions. I'm going to show you clustering of violence. I'm going to show you clustering of cholera. I'm going to show you clustering of coronavirus. I'm so kind of happy to have this example finally for the population to understand what an epidemic disease is, although of course we don't want it. And then to look at the epidemic waves, you know, here's the epidemic waves of violence. Now everybody understands what an epidemic wave is. And now here's the COVID waves. And so here again, and now as we bring this to the present, you can see the United States over the last several decades, how these waves upon waves have occurred over a different time frame. And yet what has actually happened is the country has plateaued with instability, just as it has with COVID over a shorter time frame. And what does this mean? It means that the successful interventions have not been continued, and or that the stresses, in the case of COVID, it's the violence presence. In the case of America, it's the inequity and the lack of government trust. And this is the dirty water of violence, these two variables. So it meets the criteria, it meets the definitions, characteristic signs and symptoms causing morbidity and mortality. This is all reviewed in this workshop summary. And within the summary, and I won't have time to go through this, are actually the brain pathways for copying and modeling and following and doing what others do around you, and the basis for exposure. And all behaviors are, in fact, copied. Violence more than others, none of these things are coincidences. It's the copying of behavior. And all of the violence syndromes are in this nature. And the reason why I've gone through all of this is to point out, when anyone is talking about violence in the context of a particular race, they've got it wrong. And the science shows this, that it is related to exposure, and in fact, dose dependent, just like dose dependent to COVID or flu. And that there is a susceptibility beyond dose and proximity, which has to do with grievance and other things, which are showing up in a different part of the population now, largely a white population that is taking to violence because of their particular grievance, thinking, and then of course, lack of intervention. How are epidemics stopped? Basically, there's a playbook for this that we use at Cure Violence, working with about 20 cities and about 15 countries to interrupt the spread. As for COVID, we use health workers who have access and trust and credibility, and you get results like this for violence. And so the idea of using community-based violence prevention, that was described in the last session, has more evidence than any law enforcement, policing, or punitive intervention by far, and with independent studies. And here are some of the independent studies showing community intervention in the US in various cities and also around the world, and especially even with MS-13 and 18th Street, cartel violence, election violence, we've worked all of these things. And here's the on-off in Chicago of the intervention. So violence tracks to exposure and not race, and to the intervention. This is the best book I know of a friend of mine and in fact a board member who describes how Blacks have been framed into as if they were more violent. And this is the science behind how this is simply not the case. Let me go to COVID. We've just talked about the amount of violence that has increased in the last several months, an average of 24%, an average in the 50 largest cities. In Latin America, it's the same. And anywhere anyone's looked, domestic violence is up. As is violence against children, suspected or known. Hate crimes have gone up, suicides, global conflict being predicted. And here shows that it is increasing from the pandemic, not related to the protests. And what I'm moving into now is how infrastructures for any epidemic control. When I was working TB, Africa, and child mortality, we rapidly used the infrastructure there for cholera, which we didn't ask for, came out of the blue, just as COVID came out of the blue to us here. So we used our infrastructure, and Mayor de Blasio, because we had 200 workers in 24 communities, began to use the Cure Violence workers for COVID, for social distance and so on. And we put out materials, we used our structures, and the health workers. This is before masks, our health workers. And then there's our health workers in Asia as the much of the answer for epidemic control. Of course, there's many more. Now, I want to add, So this is epidemics predict other epidemics always. This is a slide that I showed in March to my board of what is to be expected. Now, putting this into some form of order, this is the problem set as of June in my re-presentation of my board. Here's the types of violence. Here's the political divisions that are likely to get involved in this. And then we began with anti-Chinese hate and anti-immigrant, and the Jews are never left behind. And all of these things were beginning to show up according to social media of a Princeton group that we work with. And then, of course, this showing up on the horizon. And pretty soon, this outgroup becomes the other party, a much larger outgroup. So I'm talking about the moment now, the social protests as an epidemic phenomenon, us being called into working in more sites because of the defund movement. These are all the places, not all, but these are those that we found that are asking for something other than policing that largely weren't before. We're over our heads in something, I don't know what. Social unrest, here's what happens. Protests, this is what we've seen. The instigations, the mischief around this, the propaganda around this, again, the framing, race being the main playing field, although not always talked about. And then this cycle right now. Now, I want to point out that this social unrest of America was predicted to show up around now because the indices of well-being, which were going down before the Civil War, have been similarly going down according to a well-being scale. I'm going to show you on the next slide that that's this graph of well-being, and it crosses a path of both inequity growing, likewise here, and an overproduction of elites who start to compete with each other, as well as mass shootings or extrajudicial killings, which we're tracking up since 1970. So this was published by Peter Turchin in not this book, the other book, before the current president and before the current administration, that this year around this time, America was heading in this direction. And now we're seeing cycles of more misinformation, more mischief, and conspiracy feelings, theories. And I don't have enough time to talk about how propaganda works, but race is underneath it in America because it's the false belief system that allows people to believe things that otherwise make no sense. So let me see now, the election, I want to point out that by degree of racism, this is from The Economist this month, the predictability of voting for a re-election of the current president is related to degree of racism by very sophisticated survey measures. However, interesting though, that the same is true of sexism, of racism, but that this has shifted for whites with no degrees, which pushed very much in 2016 in the direction not democratic. That's less the case now. It's as if there was some new understanding of race as a result of the protests, and as a surprise finding. A surprise finding I've learned from my teacher of years ago is usually important and correct. So we've been doing some mapping of sites where there has been violence, where there's likely to be violence, picked about 10 states and 10 cities now to begin work on electoral violence mitigation in connection with the Carter Center. And we have we're starting to do training and public education to frame this problem as other than a us and them, but as an epidemic, the violence around. All right. So here's the playbook looked at in a different way that we go to for any epidemic, whether especially human to human, that don't involve mosquitoes or other things. It's about interrupting spread. It's about behavior change, the infrastructure, the system. Very, very, very weak system in America for this. Having, again, preceding this administration, the public health system in this country was extraordinarily weak compared to other places I've worked, including in Africa and Asia, in fact, in particular. And so this is this is the epidemic playbook to consider for all of these things, including racism itself and the shifting of norms. I want to point out behavior. Racism is behavior. All of these things here, all these epidemics, we think about vaccines and drugs, all of these. For 15 years, we had nothing but behavior change for AIDS. Same for Ebola, same for cholera, same for violence. Yet, we've had excellent successes in reductions in all of these things with behavior change, if you can get it to the right impact and get the credible messengers. Now, the question is whether the whole new playbook can be applied to this problem, because racism is what we at World Health would call a stuck problem. A stuck problem meaning a problem in which you're not really getting traction. And it usually means that you have to rethink the whole strategy. So this is a system change for violence. As you will see, police are way in the background of the background of the background of the background of an epidemic control system. So I'm summarizing and stopping now. What I've tried to point out that this is, in a way, one problem sets. I heard the researchers talking about wanting to disentangle these for the purposes of research. For the purposes of the real world, these things are tangled. These things are all tangled with each other. You need outreach systems that work on all of these in terms of on the ground. You need to work at 2 or 3 levels. You need a different framing, and you need a system that works on all of these things. Epidemics leading to epidemics, the playbook, largely interruption of spread. Race underlying all of these, being blamed for this, now being framed on this. And then the election, as I just pointed out, is largely about this invisibly, not only, but, and so there's a lot to do here in the American culture is a different culture than the rest of the world. We talked about this a lot when I was at World Health. I saw it as an American. Began to see Americans differently. And we have a worldview that is different than much of the rest of the world. So I think that's it. Thank you very much. We'll stop here.
Thank you so much, Dr. Slutkin. We'll now hear from Dr. Brian Williams, Associate Professor of Trauma and Acute Care Surgery at the University of Chicago and surgeon activist for social justice. Dr. Williams is an opinion writer frequently featured in the Chicago Tribune, Dallas Morning News, and he hosts the podcast Race, Violence, and Medicine. Dr. Williams.
Thank you for the invitation. Appreciate being a part of this. There's been some great discussions. And let me make sure I'm able to share my screen here. All right, we've made it past that first Zoom hurdle. I appreciate the opportunity to come and speak tonight. Clearly, the world has changed since George Floyd's death a few months ago, and even though it's about 4 months now, we're still having protests across the country, still every day since that happened. And what we've seen is that COVID has unmasked so much that was kind of hiding in plain sight in regards to healthcare inequity. And as my role as a trauma surgeon, especially here on the south side of Chicago, I can talk about what that means for gun violence, but also how gun violence fits into this larger narrative about what it means to achieve health equity within our country. So I'm going to use Chicago as an example, and I just want to say, like, there's so much more to Chicago than what we see in the media when in regards to gun violence. It's a very rich city with a lot of history, and there's so much more to it. So I sometimes hesitate to do this, but I think it's important to use what I know in my experience to illustrate a larger topic that's impacting the entire country and how we can collectively make a difference. Now, what you see here is the Chicago Tribune homicide heat map. This is published about weekly, maybe every 2 or 3 weeks in the Chicago Tribune. And the red dots signify firearm-related homicides within the city of Chicago. And you'll see that the red dots are concentrated on the south side of Chicago and the west side of Chicago. And those are the parts of the city that are predominantly African-American, racially segregated, high levels of violence. And you also see that most of the victims are Black. So there's a huge disparity geographically with the gun violence. There's a tremendous disparity in regards to race and ethnicity of the victims. And I'll let you know that these red dots only represent the homicides. I did not overlay the non-lethal injuries, which would pretty much fill up this map. So note this. One day I was sitting in my office a few months ago, and I saw this map came out from the Chicago Department of Public Health. This is back in June. It's sort of the height of the, I shouldn't even say the height. COVID has been kind of a rolling mass casualty event. But at that time, when this came out, it showed the COVID-related deaths within Chicago. COVID-related deaths. And the purple dots represent Black victims of COVID. And I saw the map and I was like, this looks very much like the homicide heat map I was looking at. You see the concentration of deaths to firearms in the same geographic area as deaths to COVID. So the question is, why is that? There is a lot more to the story. And that's where we come down talking about structural violence, structural racism, systemic racism that contributes to these disparities. Looking at some other data, this came from the Erickson Institute here based in Chicago, which showed that 60% of young children live in geographic areas where over 90% of the homicides occur. So what that means is that there is a concentrated geographic area within Chicago where most of the kids are experiencing the homicide, violent exposure. So if you guys think about what that does to the development of a child, there was data that shows that for every gun-related homicide, there are about 20 people that are impacted by that homicide, whether they are the ones who lost a loved one or they witnessed the violence and are suffering from the post-traumatic stress that comes from that. So one death, 20 people are affected. When there's your children, you can imagine what that must do to their long-term development. And of the top 5 areas within Chicago, 3 are within the area that is served by the hospital where I work. So we are in proximity to this area that's suffering a lot from the violence, but there are other issues on top of that. So let's talk about the social determinants of health. Listen, social determinants of health are a manifestation of systemic racism. This is a manifestation of policies that go back centuries that were intended to exclude Blacks from mainstream society. And on the left, we see these determinants of health. And on the right, you see our expenditures for treating it. We talk a lot about we need to increase access to healthcare, right? The safety net is going to increase access for the underserved. We need to somehow reduce the barriers to getting to healthcare. When the reality is that access to healthcare is such a small part of what it means to be healthy. But you can see we spend about 90% of our healthcare dollars are spent on access. What we should be doing is addressing the other social determinants, which again, these are the end result of systemic racism and structural violence. So genetics, we can't impact that, but the other things we can. Socioeconomic issues, healthy behaviors, the intersection of all these different determinants. And what are some of these determinants? Education inequality, income inequality, cradle to prison pipeline, redlining, environmental injustice. There is so much that's interplayed that are what we call social determinants of health that again are the end result of many years of intentional policies meant to racially segregate certain communities, that they're now suffering from the toxic and negative health impacts. And that also manifests with gun violence. Now, what does that mean? How does systemic racism play out in the numbers? Here in Chicago, we have the distinction of having the largest life expectancy gap of any city in the country. It's 30 years. This is a few miles going from north to south that the life expectancy drops significantly. New York, Washington, D.C. is number 2, and New York is number 3. And why is that? Again, these social determinants, the structural racism, the systemic racism. We have communities that are isolated, that there's income inequality, poverty leads to violence, violence manifests as gun violence. So we think of gun violence as this entity that exists on its own, but to reduce gun violence, it involves addressing that as a public health issue, but there are several other issues that intersect that we can address collectively that will not only reduce gun violence, but in essence, uplift communities that are suffering right now. And part of that now is actually happening. Since George Floyd, we can talk about systemic racism in a forum like this, and people don't tune out. We come here to discuss this, and we recognize that is a public health issue that we must address. So seeing the connection between COVID and gun violence, connecting the dots to so many other issues, shows that there's a lot that we can do. And it seems like this insurmountable mountain, but if we just focus on the parts that we can do and recognize that doesn't exist in a vacuum, then I think it's possible that we can certainly make a difference. And beginning with this discussion about the impact of systemic racism and social determinants of health on gun violence is a step in that direction. I want to thank everyone from SAFE for the invitation to speak here tonight. And I look forward to, you can connect with me. Here's my contact information. Feel free to reach out to me. I look forward to participating in the Q&A. Thank you for your time.
Sorry about that, I was muted. Thank you so much, Dr. Williams. We are now excited to introduce Kayla Hicks. Kayla is the founder, president, and CEO of the Sustain Equity Group, which works to support the advancement of Black women as leaders in violence prevention. She also serves as a senior advisor to the Educational Fund to Stop Gun Violence. We will be learning from Kayla today about the preventable death of Black females. Kayla, sorry, you're still on mute. There you go.
Yeah, it keeps popping up randomly, asking me to unmute, but I was saying thank you, Selena, for inviting me to this conference and to say thank you to everyone with Stand Safe for all that you're doing. And more importantly, to recognize the value of the community voice in these spaces is tremendously needed all across the board, and hopefully we'll see more conferences inviting the community voice and to the table. So my presentation will be a little different because it's coming from the community perspective and the community voice. Now, I do have some technical issues with Zoom, so I am going to share my screen and try to briefly get through the slides, because I know that we are on a time scale here, and I know that my colleague Tiffany Garner will be going into much detail on some of the areas that I'll be covering. So I will go ahead and start here, and I'm going to stop my video and start my screen sharing. There we go. I think we have it. Are you able to see that?
Yes,
Yep.
we can see it.
All right. I am definitely, is that full screen or a no?
No, if you start the slideshow, we'll be able to see them full screen.
My computer is just on a little delay here for some reason. All right. So my organization, Sustain Equity Group, our mission is to support and develop the advancement of Black women as leaders in violence prevention efforts by providing evidence-based professional, educational, and entrepreneurial training and networking opportunities. You can find more information on my website. And our guiding principle is that building an authentic, powerful, and effective grassroots gun violence prevention GVP movement will only succeed if the movement is committed to equity for women of color, particularly Black women, and that individuals and organizations have the tools and training to make good on this commitment. I'll be talking about systemic racism in Black females, gun violence as a public health issue, and what you can do, some of the things that you all can do. So depending on who you're talking to or what you're reading, somebody might define systemic racism differently, but for me, I'm going to go with a system of structures that have procedures or processes that disadvantage Black and brown people. One of the commonly used examples, and it was just mentioned a moment ago, a systemic racism is the redlining system, which was used by some banks in the real estate industry that outlined the neighborhoods where people of color lived in red ink. And if you lived inside the red lines, loans were considered risky and banks were less likely to give loans or invest. So these types of practices exist in many other forms today, and that's what we're talking about today when we talk about the systemic racism and gun violence. So right now, I think one of the easiest things that I've learned to do is to share the Black female experience. And typically, most people understand the experiences in two ways, and that's Hidden Figures and The Help. I don't know if anybody has watched the movie. If you have not, they're good to look at. But the reason why I use them is because typically Hidden Figures look like that individual that is an innovator, is doing the work and creating the results that we need to have impactful change, but not getting any acknowledgement or credit. And that's typically what we've experienced when it comes to the Black female experience. And thank God today, we don't necessarily have to live through that in the way that our ancestors and others have. We have phenomenal individuals that are not hidden figures, like our Dr. Shawnee Buggs, a researcher that is doing just wonderful, life-changing work, and I really enjoy working with her. And then also we look at The Help, where Black women are projected as a nanny or a field hand or someone to do the work that others don't want to do, or they don't feel as though anyone else should be doing. So we're looking at Black women in the spaces of consistently always being in this negative stereotyping space, which is very harmful in the way that we show up and how we're seen. We've seen historically that Black women are looked upon as being aggressive and loud and not more masculine, and that we don't need protections because we can protect ourselves, and all these things are not true. And that kind of trauma just continues to keep deepening the issues that we are experiencing today as far as health-wise. So one of the most important things that I read this year and I read a lot, but this one has always stood out to me, is a statement by Dr. Kara King. It's really important that people understand the historical context behind why racism affects medicine. Dr. Kara King, a board-certified obstetrician and gynecologist, told Today, citing J. Marion Sims, known as the father of gynecology, King explained that modern women's health care was developed without consent of the bodies of Black women. Sims experimented on enslaved Black women without pain medication, and the ideal that Black women feel less pain persists today. It's racism, not race, that affects Black women's health, she said. And I think that is a very telling statement. The impacts of systemic racism in Black women. When I was looking at the leading health issues, I wanted to kind of pull out some of the most important things for today. And we look at heart disease and obesity and chronic stress and gun violence, and would love to have more conversation about adverse childhood experiences and how that's linked to chronic health conditions. But more importantly, looking forward to having more conversations about how heart disease and obesity, what trauma contributes towards that when we're talking about gun violence, and we're talking about daily gun violence, and then we're talking about negative stereotyping, and we're talking about these preventable diseases that are killing Black women, that addressing the root causes of gun violence would actually save lives. So we're hoping to make sure that we are out in the front and doing a better job at making sure that gun violence prevention becomes a leading public health issue, as well as in combination with public safety, public policy, our legal scholars, and looking at behavioral sciences and making sure that all of these things are working together, and doing a much better job at making sure that communities are aware that there's this myth that Black women are always fat and unhealthy, but there's never the conversation for as many as women, and I've spoken to hundreds of women nationally, for as many as women as I speak to, Black women, about obesity, they are not aware that stress contributes towards that. So there's so much to be learned. And we look at some of the disparities where we talk about the health insurance coverage and maternal mortality and injury, and underrepresented in clinical trials that require consistent and or overrepresented in studies that do not. Rarely in positions of power within gun violence prevention efforts are key actors in the policy-making process. And Dr. Roger Mitchell says it is impossible for medical and public health communities to have a conversation about health equity without speaking about violence. And that, in fact, is what we are working on every single day, is to make sure that from taking institutional knowledge to a local level, and also being able to be in a position where now I'm here from a local level, bringing information to this institutional space that you all are in and championing for us. So why is gun violence a public health problem? And I will go straight to the last bullet. This is gun violence acts like an infectious disease. If untreated, it spreads within communities from one individual to another. That is very important for us to have people like yourselves helping to give more information to communities that are impacted, and where and when you can't give your time, because we know you're all working on your 30th hour, is that how can you get that information to your patients and communities or to your colleagues to help bring this institutional knowledge down to a local level? Understanding the root causes of firearm violence. I know that my colleague will be covering some of this, I believe. So looking at exposure to violence and has lasting impacts on health, well-being, and development associated with depression, substance abuse, post-traumatic stress disorders. And I think one thing I can say about PTSD is that, you know, while all these things do impact others, I'm specifically looking at how Black women are impacted in this area, because Black women are typically going to be doing quite a few things. We are going to be the ones that are championing the charge to fight for gun violence prevention, for voting. Black women are dying as well, and at a disproportionate rate. And I think that we need to do a better job at finding information and getting information out so that we better understand the impacts of gun violence on Black women, because Black women are also going to be taking care of the individuals that have survived. Black women will be responsible for burying. Black women will be responsible for caring for the ones that have survived, and also visiting incarcerated individuals, loved ones. Black women are overall going to be doing too much without having support, because either they are going to continuously work until they cannot work anymore, until their health just gives out on them, or they are going to be put in a position where sometimes they don't have the information that is necessary for their communities to improve what issues we're currently having. And, you know, one thing that I would like to mention about Black women and working in the domestic violence space is that I work with a lot of Black women that are running domestic violence initiatives and also leading domestic violence organizations. And one specific individual is Miss Carol Adams, who's also a law enforcement officer and the executive director of the Carol Adams Foundation. And what we have found in these conversations is that there is not enough information. There's such a gap in research, and I'm happy to be working with Dr. Shawnee Buggs in hopes in the future to start to narrow this gap. But there's such a big gap there when it comes to getting the information on domestic violence and what that looks like for Black females, because we're underreported in that space. And now that we see the social unrest that's not new, we're looking at something that is now being exposed because there's now video available to see what is happening. So this is not a new conversation for many of us. It's just new to so many that we're not able to see it and hear it. Now they can, so they can believe it. But when I speak with Carol in general about how she gets her data, she has a very difficult time at getting what she needs, because we're noticing that Black females do not call law enforcement unless it is like the absolute end where there is no more that they can take. And even in that circumstances, don't show up for court dates sometimes because they don't want to see the Black male to go through a system and actually be penalized in a way that would be very different from non-Black males. And what we look at when I'm talking with her is that she does her own research. She's not trained in this area. This is not what she does. She is a sergeant, a law enforcement officer for over 24 years. So she's not trained to do that. But what she has to do is take and record the information the best way that she can, because the females are not reporting, and they're not comfortable with going to the police. So we're trying to find better ways to be able to utilize this information that's being captured nationally from individuals that are taking records of what's being reported to them and not being able to do anything with it. So we're hoping that we'll see better relationships with individuals such as yourself to help further that research and bring that into a more academic space, so that we are able to start counting the data that they have as a way for us to fix the problem that we're seeing in Black communities. And now with the social unrest and law enforcement, it's more likely that we're going to see a decrease in these phone calls, because from what I'm experiencing, families are terrified to call law enforcement because they're now afraid that law enforcement is going to not only do some harm to the individual that needs help, but more importantly, harm others in the family just because they're there. So I think these are really important conversations that we have to have. Communities of color are disproportionately impacted by firearm violence. We know that the #1 cause of death for Black males under 55 is firearm violence, and One thing that I think is more important for me is the Black female who often gets lost in the conversation. So Black females are also disproportionately impacted by gun violence, and Black females are 3.5 times more likely to be victims of gun violence than white, non-Hispanic, Latino females. The disparity is even more pronounced among teen and young adults and young Black females ages 15 to 24. I'm sorry, I didn't mean to push that slide so quickly. I know I'm running short on time here. The quick facts about firearm homicide, you can find all this information on www.efsgv.org. The Educational Fund to Stop Gun Violence has a very comprehensive library of information for community violence and firearm homicide. But I do think that it's really important that we focus on Black Americans are over 10 times more likely to die by firearm homicide than white Americans. And what can you do? Addressing gun violence through a public health approach. So 2 things here. Public health brings together institutions and experts across disciplines in a common effort to develop a variety of evidence-based interventions. So I like what Garen had said earlier, you know, don't choose, just find what you can do and what you're good at and do it, because there's so much that can be done. If everyone picks where they're best at, we'll be closer to getting some effective results here in making sure that we're saving lives. A public health approach is multifaceted and comprehensive, addressing both unregulated firearm access and the social, political, and environmental factors which contribute to gun violence. So some of the things that you can do to help as well is support Black doctors and researchers and also public safety experts. They need your support and partnership. Also providing as much information, digestible information that families and communities need in regards to trauma. We are seeing that many of our communities, and I've worked across North America for over 30 plus years, still believe that PTSD is a war disease, that it doesn't just happen to someone that's exposed to everyday violence. So there is a dire need to have information ready and available so that people understand the grief process, so that they understand the impacts of trauma, so that we can better respond to the events that are happening in these communities in a more manageable way, because most of the individuals I work with believe that when they're angry, that, you know, they're crazy, and that they just don't embrace or understand what trauma actually is and what trauma actually does. And I think it's important that we start providing more information on that hand. Supporting Black-led organizations and partnering with some community organizations, such as the one I mentioned, like Carol Adams, the Carol Adams Foundation, where when you can lend research assistance and helping in that way would also be very life-changing. So in conclusion, gun violence is a public health epidemic which impacts Americans of all walks of life. We need a wide range of evidence-based public health solutions to effectively prevent gun violence. And these solutions include comprehensive programs which engage the communities and people most impacted by daily gun violence. And I will leave it there. You can reach me. I have my email, my phone number, and any information that you need from me. Please feel free to contact me, and also find additional research resources at the Educational Fund Coalition to Stop Gun Violence. And I will stop that there.
Thank you so much, Ms. Hicks. So we're actually going to switch the order of our presenters quickly. So we'll have Dr. Fenton speak next. Dr. Rebekah Fenton is an adolescent medicine fellow at Lurie Children's Hospital of Chicago. Dr. Fenton has dedicated her career to advocating for marginalized youth populations with a focus on the experiences of Black youth. Recently, she's become involved with physician organization and advocacy for the movement of police-free schools. And we will learn about this work from her today. Dr. Fenton?
Oh, hello, sorry, I realized I was muted. I have slides if you don't mind pulling your screen down so that I can share mine. Awesome. Okay. Well, thank you so much for changing up the schedule for me. I'm actually practicing these principles right now. I just started my MPH, and so I'm literally like in between classes, but I'm really honored to be here, especially with such an all-star panel and having people that I deeply respect in medicine and healthcare broadly to be able to learn from them. And I'm hoping that my experience, especially as a trainee, can be applicable to you all as medical students, realizing that we all have opportunities to be able to advocate for issues around violence at any stage in our career. So today I'll be talking about Chicago, a case for police-free school advocacy. So I think actually Dr. Williams already referenced the school to prison or cradle to prison pipeline, but ultimately just wanted to describe that as the context for understanding why police and schools is so harmful, particularly to youth of color. The quote above is one of the great examples of that, which says, many of these children have learning disabilities or histories of poverty, abuse, or neglect, and would benefit from additional educational and counseling services, but instead they are isolated, punished, and pushed out. Students of color are especially vulnerable to push out trends and the discriminatory application of discipline. And that's from a report from the ACLU. And so there's various components to what contributes to the pipeline. To start with, public schools are very poorly resourced, and those are especially filled with students who are Black and brown. And ultimately, students know when we are invested or not in their care or in their well-being. And so by attending schools that don't have the supplies that they need or the programs to be able to see them thrive, they ultimately recognize that it seems as if the system doesn't care and can become disinvested in school or not allowed opportunities to be able to pursue interests outside of academics. Second are zero tolerance policies that essentially kick kids out immediately after things like finding drugs in the classroom or other non-violent offenses, and ultimately then students also are sent home where they essentially aren't having any access to school, have issues with being able to have re-entry into classes, and that being also just the sense of being disconnected with the school community. Today, I'll primarily be focusing on the school resource officer program, which is ultimately placing officers in schools and making students much more accessible to being put within the system. And then finally, unfortunately, some students then also are become incarcerated at juvenile detention facilities, which often do not provide educational support. And so students are then also taken out of the school environment and have very significant difficulty with reentry. So then on the left, I wanted to highlight some of the statistics that are important to point out. And so the first is the zero tolerance discipline that I was mentioning earlier, and how that has resulted in Black students facing disproportionately harsher punishment than their white peers. And as you can see here, while we've got enrollment for white students is 51%, multiple suspensions is much more significant for our Black students versus white students. And that Black students represent 31% of those school-related arrests, and there are 3 times more likely to be suspended or expelled than their white peers, and that ultimately students who are suspended or expelled for discretionary violation are actually 3 times more likely to be in contact with the juvenile justice system within that following year. So I wanted to specifically, again, focus on what they call the school resource officer program, or ultimately police officers in school, recognizing that one, actually, officers are the most common reason why guns are in school, and also the fact that it's actually mass violence with shooting in schools that have led to this resource officer program. We've already talked about how police are not the answer, and yet we'll talk more about kind of the harm that this program intended to be able to prevent mass shootings is actually inflicted on all students, but especially students of color, those with disabilities. So the presence of police officers in schools increases the risk of youth incarceration, and so increased reports to law enforcement for weapons, drugs, and other non-serious violent offenses that ultimately has disproportionately affecting youth of color, with 95% of police incidents in Chicago involving youth of color, and there's very similar numbers nationally as well as in other cities. Can also lead to the criminalization of adult behavior. There's a couple of stories that have stuck with me of hearing about youth experience this summer. One being a young person who left a basketball game, returned and didn't have his ID, and was ultimately arrested for 6 hours. and a second of a young person who had learning difficulties, brought out their phone in class due to a moment of distraction. Ultimately, a police officer was called and the student was actually dragged down the stairs in front of the presence of their parents, all just because of having a cell phone out. So in that particular situation, that young person actually experienced physical harm, and there's plenty of cases of that. And there's actually a website that keeps track of these events across the country. Students have also reported some sexual harassment, saying that officers are making comments based off the clothes they're wearing, or even reports of sexual assault. Here in Chicago, there's been plenty of cases of students being reported to gang databases based off of just who officers see them with, and also families being reported to ICE, as well as the psychological stress that I think is one that is hard to be able to necessarily capture, but just realizing that I think the schools have a much more positive view of what these officers bring to the school, that they're a part of the school culture and their goal is to create positive relationships. But as we've just described, violence is happening in their communities, and especially some of those against unarmed people of color. And so those are the same badges, the same uniform that they have seen those events occur. And so to see that person in an environment that should be safe as your school can be one that definitely creates distance for youth in their school environments. So I wanted to focus a little bit on the inequities that we see within Chicago. So we've got students in CPS, 15% of them have individualized education plans or basically some type of advanced learning need, and yet twice as many of them are having police notifications. Similarly, Black students make up about 36% of the school population, and yet 66% of school notifications. And so continuing, hopefully after this, you're like, why would officers ever be in schools? And yet as Chicago and many other cities advocated for their removal over the summer, there were plenty of arguments to try to say, to advocate for their purpose, a positive purpose. And so one of the most common ones is that officers prevent school shootings. In reality, that is not true. And that are actually a study of multiple school shootings and found that when somebody was able to intervene, it was actually most commonly by somebody who was unarmed and was able to trained in de-escalation to be able to address the situation, but that ultimately none of them were ended by an armed staff or officer. There's also this thought that officers reduce criminal behavior, and instead, actually, there's a study that showed in some of New York City's most dangerous schools that actually the police presence did not change anything after an increase. There's a general idea that SROs make schools safer, and I think I'd argue with the psychological effects and the physical effects that I just described, that students actually feel the opposite. There were plenty of other arguments about that police presence in school prevents dropout or improves academic achievement, and there's been no studies to show any of those. And I thought one of the most harmful arguments was this idea that officers are there to protect youth from the community. And the reality is these youth are coming from those communities, and we've already talked about systemic racism and ultimately how little funding we're giving to really the majority of the things that determine people's health. And so this funding that we're giving to schools to protect them from the community around them should ultimately be funneled into that community. And so then you're probably wondering, well, as a doctor, why did I get involved in this? And I felt like we could make a health argument for this. First of all, we know that ACEs lead to long-term physical and mental health effects, high blood pressure, diabetes, smoking, suicidality, lower life expectancy, plenty of others. We've also seen that expanded ACEs, such as community violence, negatively impact health. And so it's not necessarily just even your individual experience, but other things within your milieu. That the presence of police can be traumatizing both physically and emotionally, and that ultimately, because of that, the presence of police can be associated with some social emotional symptoms, anxiety, restlessness, lack of motivation, inability to focus, social withdrawal, and aggressive behaviors. And you can just imagine really with any of those, but especially with the combination, how that might negatively impact the student's ability to engage in the classroom. And so then I think as people have been calling to defund the police, whether that be in school or in communities at large, I think often that message has been watered down to say, no, we don't really mean defund the police, we just mean more resources. I think we all have to acknowledge there's a limited amount of money, and also that it's not by accident that communities of color are both over-policed while also being drained of the resources to be able to help them thrive. And so I think it is really important to be able to address both and to have that funding shift from harm into places that would be actually helpful. And so again, in Chicago, as of last year, the budget for just school resource officers in The school system was 33 million, thanks to the protests that have been happening for years by youth of color and the community organizations that support them. That funding was reduced to 12 million. There have been several school districts in the last few months who have now made police-free schools, and I'm excited to see what ultimately happens with that. Unfortunately, Chicago, at least this year, was not one of those, with losing just by one vote when it was voted in our school board. But ultimately, and kind of before this last school board meeting, students met downtown and held a protest, and basically were asking themselves, what would you do even with that 12 million? And I think it's important to highlight the things that they're asking for, because they ultimately are the experts of their lives. And they were saying healthcare, CS classes, no student fees, nurses, and I think most importantly, one of those being not police. And I think as we talk about where is that money being taken from, these are all graphs that were completed by the ACLU, specifically looking at the student to school-based mental health staff by state. And so there actually are standard recommendations for these providers within schools and what would be considered an adequate number of them within each environment. And the reality is, you look at the slide from afar, is that basically most states aren't cutting it. Specifically, we've got schools to counselor ratios here, school to social workers here, school to psychologist, and student to nurse here. But that ultimately, in summary, there are 14 million students who are in schools with police, but no counselor, nurse, psychologist, or social worker. And I think as healthcare providers or future physicians, I think we can all understand the harm of that. So what did we do about it? Basically, I just decided this summer, I was like, hey, I feel like this is something that I can get involved in, that physicians previously hadn't necessarily been a part of this conversation, at least in Chicago. And I got together with some friends and we're like, how can we help? So we tried to show up everywhere as possible, contributing written and public comments to city council meetings and board of education meetings, even meeting with board members one-on-one. We did a social media campaign for other healthcare providers, realizing that people are often working and don't necessarily have the ability to contribute to these daytime meetings. We participated in youth-led rallies and really wanted to show our support for the ongoing efforts rather than trying to come in and make this about us. We also were able to participate in a live stream that the teachers union had put on about this issue. I had an opportunity to present on the local news and then also make presentations like this to other providers to be able to energize and mobilize them to take action. And so that's all I have for today, but I did want to, of course, thank first the tireless advocacy of Black and Brown youth organizations who honestly continue to inspire me and have been the people who keep me going through the pandemic, especially in just kind of the barrage of bad news it feels like 2020 has been. And of course, what I call my MD partners in decriminalization, the other physicians who are all either pediatricians or family medicine doctors in Chicago who readily answered my texts and have been a source of support through this past few months and the work that we've been doing. Thank you.
All right. Just give me 1 second. We are on our last presenter here. Last but not least, we have Tiffany Garner. She is the Community Violence Initiative State Manager for Giffords, who's one of SAFE's partners. She has spent her career working with community members, including researchers, victims of violence, and law enforcement, to establish innovative community-based initiatives to reduce violence in our most vulnerable communities.
Well, all right, good evening, everyone. I promise to be really short and sweet because I know you all have been hanging there with us, and I know we're a little over time, so I want to be mindful of that. I'm just going to do a quick overview, just kind of wrapping up everything from what my colleagues before me have already said. So bear with me as I work on sharing my screen here. Let's see. Okay. All right. Can everybody see?
Yep.
Everyone can see the slides. Okay. All right. Let me just really quickly get to from the beginning here. Okay. Great. All right. So once again, so happy to join you all. I'm with Giffords, Courage to Fight Gun Violence. We're based out of Washington, D.C. So with Giffords, I work in several states around the country trying to work on lobbying for gun violence prevention laws, mainly around community-based violence. So looking at funding and how we can get that funding to trickle down into a lot of the community-based programs on the ground who are actually doing the work. So that's a lot of my work currently with GIFT. So just really super quickly, just wanted to highlight a couple of things. The necessity of community-based violence interventions, as my colleagues, a lot of them have alluded to already, how important it is to for us to really focus on supporting these efforts on the ground. I put a little quote here that we have at one of our reports with Giffords. We have several reports, and I have it on another slide for you guys to take with you to just kind of do some research on this. But it looks at gun violence, how it costs Americans $229 billion a year. That's a lot of money. That averages out to about $700 per person, right? And you're just looking at how all of us shoulder the cost of this. And so it looks at how this is a problem for all of us, as everyone has already talked about tonight, but how we can work together to really solve this problem. I will not go through all these stats with you guys, but just wanted to highlight the one at the top about how gun homicides really are concentrated a lot in impoverished, underserved communities. And so we also look at how young Black men, oftentimes these everyday shootings they are underreported or they're not reported at all. So definitely a major problem that we have seen. My colleagues have touched on the historical aspects of race-based policies and how that has contributed to marginalization and poverty. Areas that experience more poverty are more likely to see more cases of victimization, right? That doesn't mean that everybody in poverty will be prone to violence. It just breeds environments such as that. And so all these other policy-based historical issues that still impact people today, it's still a challenge. We all can work on that together. I think Ms. Kayla alluded to this, that gun violence should be declared a public health crisis. I've listed here for you guys a couple of the community-based interventions. Dr. Slutkin, who presented first, obviously is the founder, originator of Cure Violence, but another type of community-based violence program is group violence intervention or focused deterrence. So we have a lot of cities around the country who use this model, and as well as the hospital-based programs. This is the website you guys can please feel free to visit. This has some of our reports that we have published that gives more insight on why it's so important to invest or to look at how these programs really reduce violence. So I highlighted a few of these reports that you'll find on our website, and I definitely encourage you all to take a look at the last one, In Pursuit of Peace, is the one that's a combination of the community and law enforcement, and how together, and I know today's world, that may not be as popular, and maybe not a lot of people want to address that, but there have been studies and reports and done in certain communities where law enforcement and community strategies have worked together to reduce violence. I want to move forward. I was going to go over a little bit of the breakdown of why these programs, kind of what they look like, but for time's sake, I really wanted to highlight the importance of looking at how we need more advocates. We need more public health advocates. I know some of you all on this call today may be from medical students to other public health professionals, but we definitely need people pushing and advocating for policies. So far around the country, we do see more people more legislators who are funding this work on the ground, and that is hospital-based as well as those programs in the community. I just highlighted a few for you all. In Baltimore, we worked on trying to get the governor to fund the violence intervention. VIP stands for Violence Intervention and Prevention Funding. It passed in both chambers to award $6 million, but of course the governor vetoed that. So that is still a work in progress. In New Jersey, we see that the leadership there when the state decided to invest $20 million in hospital-based programs. And as well as in California, we see that they're trying to allocate $9 million. Well, it is a reduction from 30 million, but at least it's something. So my takeaway for you all tonight, if there's a way that we can do more work around advocacy in your respective roles, that would be great, because we do need more funding for this. Call to action. This is just kind of wrap up for you all, just based on what all my colleagues have said. And I'm just adding a couple things to here. Just understand personally how these race-based policies have created disparities and disadvantages. Also use time to discuss with family members, peers, and colleagues how community violence disproportionately impacts communities. We got to be able to explain why, though. We have to be able to be honest and check some of our bias and discriminatory beliefs that impact our daily work, but also look at how you can, after checking yourself, how can you check the systems that continuously keep you marginalized. Again, look at you guys may be spread all over the country. I'm on the East Coast, but just maybe look in your areas at what are the community-based violence reduction initiatives in your respective areas. How can you support them more? Elevate the necessity of legislation, as I just kind of told you all. Maybe look at ways that you can advocate and push for with local legislators, even to your state legislators, on how we can get more funding for this. Listen to those who are already serving in communities. Don't always come in assuming that we know everything just because we come from the medical community. It's important to listen and to understand what some of the organizations are seeing on the ground when it comes to community violence, and be able to consult and collaborate. And also, as I just told you guys about advocating, making sure that the funding that we're going for is sustainable funding, not just a one-time pot. We need continuous money, because violence didn't happen overnight. This is, oftentimes in a lot of communities, this is years and years. So it's going to take time to see a reduction, but we just need sustained effort and funding to get this done. So anyways, I'm done. I just wanted to just kind of wrap up our conversation tonight, which is maybe a little bit more of a legislative advocacy push, but I think as public health professionals, we should show up more in that space. When I go to lobby a lot with legislators, I don't always see a wealth of public health officials joining our forces or joining our coalition to do this work. So we need you. We need your voice and what you're seeing. So anyways, thank you all so much for your time. And I'll turn it over to Selena.
All right, so this is Julie again, and I'm just going to—
Julie, sorry.
That's okay. Just going to moderate a few questions because we're over time, and I want to thank all of you who've given those just absolutely brilliant talks. And I learned a ton, and I'm so appreciative of you giving us your time. And also all of you who've stayed on the webinar, even though we've gone over. So I'm going to just try to ask a few of the questions that have been sent to us. And to paraphrase one of them, this gets to Tiffany's comments as well. Here we are. I'm going to ask this of all the speakers. We have these very energetic, fantastic medical students on this on this webinar, who are really interested in making a difference. And some of them just very passionate, have a lot to give to the fight against gun violence in the United States, and for specifically fighting against the systemic racism that may lead to more gun violence in many of our communities. And so I'm wondering what you see what they can best offer. I will start by saying you should really, really get involved in SAFE. I'll start with that. But what do you guys see that these medical students could do in a concrete way right now to help deal with some of the gun violence issues in the United States? Dr. Slutkin, let me start with you if you're still on the line here.
Yeah, I'm still on the line. I think it's a tough one because medical students don't have a lot of time. They can connect with these organizations, any of the speakers here, to see how they might be able to offer any kind of help that these organizations already have. There's excellent community organizations in your neighborhoods who you could connect with and see what kind of help they might need as well. That's really because they're add into something that already is going on is the best thing that comes to my mind straight up.
Thank you. How about you, Dr. Williams? You have some thoughts about that?
Yes, I found that the students and the residents that are training now are like this group. They did not come to play. I find them to be. I find you to be so much more socially aware and socially courageous than when I was in school, and I'm inspired and learning from them all the time. So what they do? I think a lot of it's just getting involved locally, and also pushing your institutions to recognize the importance of not just addressing gun violence, but how that interplays with so many other issues in regards to health equity. Especially during academic education, things move at a glacial pace within institutions. But with these students that are coming up now that recognize the importance of this work the urgency of this work. You can make a difference in the community by connecting with organizations that are doing the work, but also pushing from within for change within your institutions. Never underestimate your power of what you can do.
Thank you so much, and I'd like because SAFE was started by medical students, and it's being run now by medical students. I think they've made a huge impact. So I agree that we have so many fantastic medical students out there who really can make a difference, and working at their institutions and working on ongoing projects that are in those schools. I have another question here, and I'm going to direct this one to Rebekah and Kayla. And I was wondering if you could tell us what you think have been the most successful public information campaigns that have helped Black women prevent violence in their communities, and whether you think there are things that really could be done from a public information standpoint that would help address gun violence, specifically among Black women.
Dr. Julie, Kayla had to leave.
Okay.
Yeah.
Okay. So do you have any thoughts about that? Anybody else on this have any thoughts about particularly targeting Black and brown communities and public service things that might help those communities build better efforts against violence?
Mm-hmm. Well, Dr. Julie, I'm just gonna jump in here. So with, as I mentioned to you guys before, outside of just doing the lobbying work and just trying to get funding, I do spend a lot of time on the ground with a lot of partners, just to kind of get an understanding of what they see. And so one of the things that I've come across that helps Black and brown communities is taking time to work on a lot of the potential traumas that a lot of individuals may have. Especially, I have worked a lot in Philadelphia with some healing centers there, which is where they spend time working with people who haven't been exposed to whether it's violence or whether it's traumas from the past, and they work on really taking time to really heal that aspect of them, and that then can in turn continue to help heal families and in communities and so forth. So that's something that I definitely have seen on the ground that has been effective and helpful towards healing communities.
Okay, and just as a, thank you so much. And just as a last question, and then I'm going to turn it over to Celine and Dennis. Do you see some really big gaps in the research? Any of you, and I'm going to open this to any of you, big gaps in clinical research that we should be thinking about? There are some dollars now for research from the federal government, and what would be the number one topics that you think could help bridge this systemic racism and gun violence and even the coronavirus? Where do you think the research should be done?
It's a great question.
All right, well, maybe it's getting late in the day, so I'm not going to push people too much on it. I know that there's a ton of research, and Dr. Wintemute, I'm sure, would be happy to chime in since he's doing a ton of research on his end. But let's leave it at that, and I'm going to turn it over to Selena and Dennis to close up and talk a little bit about SAFE's education efforts.
Okay, wonderful. Thank you all so much again for all of your presentations. For this second session, thank you to our speakers for sharing their unique perspectives on the deeply important connections between systemic racism and gun violence and the preventable nature of these associations. Your work is really going to allow us to acknowledge and confront the insurmountable challenges faced by our patients from Black and brown communities, and to really cater our care to the unique needs of those populations. So I'd now like to introduce part of our Safe Curriculum Development Initiative team to announce an exciting project that we've been working hard on for over a year now. Just going to unmute them now so they can join us.
Hi, everyone. My name is Jessica, and I've had the privilege to work with the group for the past few years. And so before we close today, we'd like to formally announce the rollout of Module 1 of SAFE's Curriculum Development Initiative. It's titled Physicians and Firearms, and it was developed over 3 years ago because we saw this huge gap in the medical education and addressing gun violence as a public health epidemic, and specifically a healthcare provider's role in it. And it began as a grassroots project among students and has evolved through many revisions and versions, and we're really proud to share it with you all today. It's a self-paced course, and it's divided into 3 modules: epidemiology, firearm basics, and providers and firearms. And the course is really intended to primarily for medical students, physicians, and other healthcare providers to understand the current state of gun violence in the United States, basic firearm terminology, and what we all can do in the healthcare setting to prevent firearm injury for our patients.
And these objectives are intimately linked with the topics that we've learned about from our outstanding speakers today. And we hope that you will take a look at Module 1, which we will distribute via email tomorrow to everyone who's registered for this event, as well as our over 50 SAFE medical school chapters. So stay tuned for modules 2 and 3, which will be coming soon. And we also want to take this time to recognize the other students who worked on the curriculum: Denise Kettle-Tepe, Maddie Wren, Jessica, who you just heard from, Ashley Cohen, Emily Root, and Gabriella Rader, all of these representing a mix of medical students as well as residents who are across the country from Boston, New York, Chicago, and LA. So thank you so much.
Thank you guys for that. And we just want to say thank you to all of our presenters for sharing their amazing insights with us today. And of course, for the impactful work that they're doing in each of their respective fields. And we want to say thank you to all of you, the attendees, for taking time out of your busy lives to join us for Stand Safe 2020.
We encourage everyone to visit our website, standsafe.org, to join our email list and follow us on Instagram and Twitter to keep up to date with our activities. You'll all receive a recording of this conference to the email addresses that you shared with us when you registered, and we'll be sending that out sometime tomorrow. And you'll also receive a link to view Module 1 of our curriculum development that Jessica and Christina just talked about. Everyone, please stay healthy and well during these trying times, and thank you to our many frontline workers who are tuning in today. Have a great week, and we hope to stay in touch with you all.